Josephat Ndai, and as well at Kenyatta National Hospital. And I take this opportunity to introduce today's two topics. We're going to go through Retinoblastoma and lymphomas. And we are going to have Dr. Doreen Karimi Mutua, who is a pediatric hemato-oncologist at Gertrude's Hospital. She'll be going through lymphomas with us, and Dr. Mutua is a pediatrician whose proficient for children with blood disorders and cancer was ignited during her residency training at the University of Nairobi, where she noticed that most of these children had dismal outcome due to late presentation and lack of appropriate diagnosis and treatment facilities. Dr. Mutua was a beneficiary of 2-year training program conducted as training program by Jumna University, Ethiopia, and the ASLAN project, USA-based non-governmental organization that seeks to build capacity in low and middle-income countries in treating children with blood disorders and cancer. She completed her training in May 2018 and returned to Kenya to establish hemato-oncology services that include centers of excellence for pediatric cancer care and comprehensive sickle cell care at the Gertrude's Hospital. Dr. Mutua, in July 2023, graduated with Masters in Global Child Health from St. Jude School of Biomedical Sciences, which is a boost for advocacy work in childhood cancer and sickle cell disease. She is passionate about raising awareness on childhood cancer, early detection, establishing treatment guidelines, and improving outcomes of children with cancer. She's keen on seeing the establishment of comprehensive sickle cell centers in the country so as to reduce the mobility and mortality of these patients. That's the much we could say about Dr. Doreen Karimi Mutua. Let me introduce to you our second presenter, Dr. Kaaki Kimani. Dr. Kaaki Kimani is a senior lecturer at the Department of Ophthalmology, University of Nairobi since 2001. She holds a Bachelor of Medicine and Bachelor of Surgery and Master of Medicine in Ophthalmology from University of Nairobi, as well as Master of Science in Community Eye Health at the London School of Hygiene and Tropical Medicine. She is a fellow of the College of Ophthalmology, East and Central and Southern Africa. She has been involved in training ophthalmologists from Kenya and many African countries. She has mentored many young ophthalmologists who have gone on to become accomplished eye surgeons. She has been the principal investigator and many researcher projects and published widely in peer-reviewed journals. Our most remarkable achievement is spearheading the Kenya National Retinoblastoma Strategy, which has led to dramatic improvement in the treatment and survival of children with retinoblastoma. She has been instrumental in making Kenyatta National Hospital a center of excellence for retinoblastoma in Africa. Our passion is to see every child suffering from retinoblastoma access the highest quality of treatment, regardless of their ability to pay for such treatment. Thank you. That's an introduction for our panel, for our presenters today, and I welcome them to go on with the presentation. Thank you.
Thank you very much, Joseph, for your kind introduction, and I'm honored to share this panel with Dr. Kimani, who is my teacher and also somebody I look up to. So it's a real honor. And to the audience, it's actually, I'm grateful to be speaking to you all on this golden month. We call it the Childhood Cancer Awareness Month. And my topic today is on a childhood pediatric lymphoma. So I'll take a minute and share my screen. Maybe you could stop sharing your screen if you are. Josephat, are you sharing your screen?
No, I'm not.
Okay.
The research team is doing that for us.
Okay.
Yeah. Dr. Doreen, are you there?
Yes, I am.
Kindly share your screen.
I think I'm already sharing my screen.
Okay, thank you.
Can you see my screen?
Thank you. Yeah, we can see it. Thank you.
Okay. All right. Don't know why I can't see the presentation, but I'm sure you can see it. So let me quickly open it. So today I'm honored to speak to you about pediatric lymphoma. And as you heard, my name is Dr. Doreen Karimi Mutua. I'm a pediatric oncologist at the Gertrude Children's Hospital. So lymphoma in general is actually a tumor of your immune tissue. And this immune tissue, most of it is actually found within the bone marrow, but we have
Apologies for the interruption, Dr. Doreen.
Yes, please.
We are unable to see your screen. Can you just reattempt to share again?
All right. Okay, let me do that. Can you see it now? Are you
Yes.
able to?
Yes, we can see the screen, although just put it on slideshow mode.
Okay, I have. I'm putting it again on slideshow mode. Is that okay? You can see it?
We're still seeing it's like you're having a bit of a challenge.
Actually, I'm actually on slideshow mode.
Or
Let me put it from the beginning.
okay.
Is that still on slideshow mode?
It still hasn't appeared. Kelly, Josephat, can you confirm whether you can see the screen on slideshow?
Yeah, I can see the screen from my end.
Yeah.
I don't know probably why you can't see your screen.
Okay, let me share again. I'm sharing my screen once again. And I'm putting it on slideshow mode. So yes, so as we had said, that lymphomas are actually tumors of your immune system. And if they are located within the lymphatic system, we call them lymphomas. If they are within the bone marrow, or if the issues that the mutation that causes the continued division of the cells occurs in the bone marrow, then we call it leukemia. So lymphoma and leukemia are actually a spectrum of disease, depending on where the disease started from. Sometimes we could call it lymphoma, or we could call it leukemia. So this is a snapshot of the lymph tissues, and this is where most of the time, if you have a problem of lymphoma, you would actually go on to look for most of these lymph node bases to be able to see what could be happening. For example, most of these patients will come in with either swelling in the cervical nodes, in the axillary nodes, sometimes even could be in the inguinal nodes, and all these other lymphatic spots also actually could be involved. Now, most of what we see in the lymph nodes is actually B and T lymphocytes. So even when we are talking about lymphoma, most of the time you see in our classifications, this will either be predominantly B or T lymph node, lymphocyte generated. So lymphoma, we look at it. This is actually a very common tumor in our setting. Actually, most of the time we even say right after leukemias, we have the lymphoma. In fact, lymphoma and leukemia, surprisingly in our setting, almost are competing in terms of the frequency. So in the US, then they have more of acute leukemias, then brain tumors, then lymphomas. And the major types, we have two types of lymphoma. One is Hodgkin's lymphoma, and anything that was not looking like or behaving like Hodgkin's lymphoma was lumped into another big group called non-Hodgkin's lymphoma. So non-Hodgkin's lymphoma, I almost compare it to when we say childhood cancer. You know that it's not one disease, that there are many types of lymphomas that could be within that one diagnosis. So for pediatric lymphoma, 60% is usually non-Hodgkin's lymphoma and 40% is Hodgkin's lymphoma. So when we look at GlobalCan data for Kenya, we notice that we diagnose about 3,000, almost 300 new cancer cases every year of childhood cancer. And if you look, this is the distribution of how many cases we have. And if you look at
Excuse
that,
me, Dr. Doreen.
yes,
Dr.
please.
Doreen, the slides aren't moving. Could you kindly look into it? Yes, now it's better. Thank you.
Oh, all right. I'm not sure what the problem is, but let me go on and just continue. So basically, you look and you see the non-Hodgkin's lymphoma is actually quite common in our setting, almost competing with the leukemias, and that is what I was commenting on. So we'll start with a big group called non-Hodgkin's lymphoma, and you can see non-Hodgkin's lymphoma tends to have a myriad of presentations. You can have the jaw mass that sometimes if you go to Western Kenya, you see a lot of that. For the buckets, the endemic buckets. You can have eye presentations. You can have children who have an abdominal mass. You can have bone involved. You can have also the breast lymphoma. So sometimes we have had masses within the breast, and when we take a biopsy, we actually find it's actually non-Hodgkin's lymphoma. So non-Hodgkin's lymphoma is a very rapidly growing tumor, and that was one of the big differences between non-Hodgkin's lymphoma and Hodgkin's, that non-Hodgkin's tends to be a very aggressive disease, and sometimes even like in diseases like Burkitt's lymphoma, the doubling time can be anywhere between 12 to 24 hours. They also have a very high potential for metastasis. So most of the time, by the time a patient is presenting to you, more than 2/3 of the cases will have widespread disease at the time of diagnosis. And majority of the time, the spread is usually to the bone marrow or to the central nervous system. So as we said, non-Hodgkin's lymphoma is actually a big group of tumors, of lymphomas. And most of these, what we would want you to know is that 40% is usually Burkitt's lymphoma. Once we have the 40%, around 20% is usually the lymphoblastic lymphomas. And these lymphoblastic lymphomas can either be B or T cell. And depending on how, those are the patients who will come in either for the T lymphoblastic lymphoma with a mediastinal mass, and for the B lymphoblastic lymphoma, they usually would present almost either with the lymph nodes and almost looking like a leukemia. Now, you remember we said leukemia, lymphoma, most of them, it's actually a range. And these lymphoblastic lymphomas are one of the tumors, or the non-Hodgkin's lymphomas, that we almost treat like leukemias. All right. Then we have the large cell, the diffuse large B cell, and the anaplastic large cell lymphomas. And these are basically the 4 categories of non-Hodgkin's that we have: Burkitt's lymphoma, lymphoblastic lymphoma, a lymphoblastic lymphoma, diffuse large B cell, and anaplastic large cell lymphoma. So a lot of the times we always say that most of childhood cancer does not have risk factors. We don't know what causes it, but in non-Hodgkin's lymphoma, we have found some predisposing factors. For example, familial cases are present, and most of these will have either some inherited immunodeficiencies, for example, the Wiskott-Aldrich syndrome, the X-linked immunoproliferative illness, disease, or ataxia telangiectasia. So if you see that syndrome, most of the time these are patients who you should follow up and keep on screening for lymphoma. Now, in acquired immunodeficiencies, for example, in HIV disease in children, we find that non-Hodgkin's lymphoma is actually one of those what we call AIDS-defining illnesses. So it's possible, again, in patients who've had organ transplants, there are also types of non-Hodgkin's lymphomas that they can actually get. Now, in a setting, we tend to have a lot of infectious diseases, and one of them is EBV. We get silent infections, but most of these infections also tend in general to predispose a patient to tend to have non-Hodgkin's lymphoma, and mainly we are thinking about Burkitt's lymphoma. There has been an association also with malaria, and in other circumstances, some chemicals, pesticides, and solvents have actually also been blamed for it. But this, again, is really things that most of the time epidemiologists need to go out and see what is happening in our environments, especially now that we have some areas where we do have non-Hodgkin's lymphoma. The next is how does non-Hodgkin's lymphoma present? And basically, it's variable. The severity can be from a patient who is asymptomatic to extremely sick. The time course, we've said these are very aggressive tumors, but we can have a few like the diffuse large B-cell lymphomas or even anaplastic large cell lymphomas. Some can actually present over months or years. Most of the time, they will have systemic manifestations, for example, fever, night sweats, weight loss, loss of appetite, and sometimes pruritus. So systemic manifestations are not only seen in tuberculosis. So if you see a patient who has lymphadenopathy and also has fever, has night sweats, other than thinking about tuberculosis, also think could also this be non-Hodgkin's lymphoma. And locally, you will have the lymphadenopathy. You could also have enlargement of the organs like splenomegaly, and this could be any other tissue also could be potentially infiltrated and end up with an enlargement. So again, I just put more pictures because these are our patients who have had lymphoma. For example, this boy he had a T-cell lymphoblastic lymphoma. You can see how big his lymph nodes look like. For this, he had almost about a month of treatment as tuberculosis, but they weren't resolving. In fact, they were getting bigger. And when a biopsy was taken, it confirmed that this young man had T-cell lymphoblastic lymphoma. Abdominal masses, the weight loss, and sometimes with malnutrition. So I make mention of one of the non-Hodgkin's lymphoma, which is called Burkitt's lymphoma. And this is because Burkitt's is actually quite common in our setting. And even Burkitt's itself was actually diagnosed or first discovered around the western part of Kenya and also Uganda. So we have two types of Burkitt's lymphoma. We have the endemic versus the sporadic. The endemic one is what we see with the jaw mass, and it's usually called the African variety. And most of the time it's associated with EBV infection. And then there's a sporadic where we see mainly an abdominal presentation. And a lot of the times only 20% of this disease is actually associated with EBV. Now, for the abdominal one, we don't know why, but for some reason, most of the patients now we are seeing tend to present with abdominal. Possibly, maybe there might be a change in how our environment is and the exposure to infections. And we said, how does EBV bring in this connection? And what happens most of the time, it's all about the immunity. And when your immunity is lowered, possibly by the infection itself, then these mutations actually happen in the progenitor cells of the lymphocytes. And with that, we end up with proliferation and what we call lymphoma. So how does one investigate a patient? You've already taken a history, you found some of the systemic symptoms, you found the swelling of the lymph nodes, you've examined them, you've seen a mass, or you've seen the jaw mass, or you've actually found an abdominal mass or the lymphadenopathy. So how do you take it from suspicion to investigation? And these are the things that you must really do. And we talk about a lymph node biopsy. I know we are very common. Most of the time we'll see that people want to take a fine needle aspirate, and I always say a fine needle aspirate might not be able to show you what exactly you will need to see. So a lymph node helps you to be able to visualize how is this lymph node looking in terms of architecture. What are the cells? Any invasions? Are there any parts that are actually normal? So for you to actually be able to see the whole lymph node, the pathologist will see the whole lymph node and be able to tell you what type of lymphoma it is, and maybe go on to ask for immunohistochemistry to look for the for the specific cells that are identified with that type of lymphoma. So fine needle aspirate can be talked about, and especially if you're dealing with a Burkitt's lymphoma. But Burkitt's lymphoma also tends to be quite pathognomonic. If you see it, it's actually the starry sky, and you can actually see it's a very typical presentation. You see those small cells, non-cleaved, and you see them all in that slide. So it has a very typical presentation. You might see within these cells some globules in there, and this is something that you might quickly want to do because you want to confirm. And remember, buckets within 12 to 24 hours, it's dividing and dividing very aggressively. But for other types of lymphomas, a lymph node biopsy is what we should be talking about. Then a bone marrow aspirate and biopsy is something very important, because remember also a lot of these symptoms, you'll get them in leukemia, and you really want to be able to tell, is this leukemia, is it not? And even if we are doing it also for lymphoma, we also use a bone marrow aspirate for staging. Some of the times we will be thinking leukemia, and we take the sample of blood, or we take a bone marrow aspirate and do a flow cytometry. And most of these diseases also have some molecular tests available that you can be able to tell, for example, for Burkitt's lymphoma, which translocation has happened, and that we would do either using the FISH technology or other cytogenetic measures. So that is extremely important for us to know. Other investigations, now that will help you confirm the diagnosis of lymphoma, but there are other supportive investigations that you need to do. And one is a hemogram. A hemogram, again, if you find the elevation in the white cells, then that is pushing you more towards leukemia. You might be able to see anemia or an even reduction in the white blood cells. Again, if you see of the platelets, if you see that, again, that is pushing you more towards leukemia more than lymphoma. Majority of the time for non-Hodgkin's lymphoma, a hemogram will usually have more or less the normal white cell count. The anemia might be present because of the fast division of all these cells, but the platelets are usually also within normal. Now, very important is the chemistries. And this is one that you must remember, that because of how aggressive non-Hodgkin's lymphoma is, we tend to have a high burden of the tumor cells. So these cells are dividing so quickly. Some of them are dying off before even our treatment, and others, even as we will anticipate to give chemotherapy, will actually also die off quite quickly. So you must really be looking out for what will be able to help predict this patient is at high risk of tumor lysis syndrome. And tumor lysis is an oncologic emergency, and especially for tumors like Burkitt's lymphoma, If you're not thinking tumor lysis, most of the time you will lose that patient. And that is why we need to do our uric acid, be able to do the lactate dehydrogenase, a simple test that you can do, but it tells you how the cell turnover is and what is the burden of the disease and the risk of tumor lysis. Do your urea and creatinine. And why are you doing that? Because you know most of these tumors, most of these cells, and most of these byproducts of all these metabolites will be excreted through the kidney. So you need to have kidneys that are actually working very well. Once you suspect, please start your patient on fluids. Give them a lot of fluids so that we make sure they're passing urine. And as they're passing urine, most of that uric acid will be removed. Most of the potassium will also be removed. Most of the phosphate will actually be removed, and you avoid tumor lysis. This is extremely important. Now, other imaging that we do still again for checking in terms of staging will be your CT of the chest and abdomen, and where you have the FDG PET scan, that also can be done to be able to actually stage your patient and be able to know how far has this disease gone. Remember, non-Hodgkin's lymphoma is actually a very aggressive disease. By the time you're seeing this patient, there is disease possibly everywhere else in the body. A bone marrow, we talked about it, and a CSF, and you'll understand when we talk about the staging, why it's important to have a bone marrow aspirate and a CNS. Remember, if you have a single tumor in one side of the body, either in the mediastinum or the abdomen, that is stage 1. If you have 2 nodal areas or a primary GI tumor that is actually fully resected, for example, we have some patients who present with intussusception. The surgeon goes in thinking they're going to find intussusception. They actually resect, and when we look at it, we find out that this patient actually had a lymphoma, but he's been able to resect all the tumor, so that becomes stage 2. Now, stage 3 is any tumor that the surgeon is not able to go in and do a full resection. If a patient has nodes above and below the diaphragm, or if you have any paraspinal epidural tumor, that becomes stage 3. Stage 4 is very specific. 2 things, either disease in the bone marrow or disease in the central nervous system. Either you find blast in the CNS, or you find blast within the bone marrow, and then this really will become stage 4 disease. Remember, that's what makes pediatric NHL stage 4 is either CNS disease or bone marrow disease. So how is NHL treated? The mainstay of treatment is actually chemotherapy. Remember, sometimes the surgeon will have to go in to get you a biopsy or to actually do the resection of the tumor. That can be used too. Radiation sometimes can be used, especially when we have some obstruction. For example, we've had children who present with a mediastinal mass, and you need to quickly go in and reduce that mass because it's actually causing superior vena cava syndrome, and we order for emergency radiation. Or you have a paraspinal mass that is causing compression, and we know this is going to cause spinal cord compression, which is an oncologic emergency, and we go on and we give emergency radiation. Most of the non-Hodgkin's lymphoma chemotherapy really is what we use, and we have various protocols that we do use. Remember, again, lymphoblastic lymphoma, we treat it as acute lymphoblastic leukemia. So we use the protocols for leukemia, similar, but for all the other non-Hodgkin's, we use high-dose intense chemotherapy, and we treat them, and even sometimes we do give targeted therapy. For example, the Burkitt's lymphoma, where we have an anti-CD20 rituximab, and we use that quite often. Now, can we get some complications? And this is what I'm just putting it here again for emphasis. Really, we can have a mediastinal mass causing superior vena cava syndrome, and these are patients who come in and they are breathless, they can't lie down flat, they feel there's something actually in their chest, if these are patients you find, if you make them lie down flat, you will completely cause complete obstruction, and this can be a very huge emergency. Some of them actually lose their lives just by making them lie down flat. So remember, if you have a patient you're suspecting of lymphoma and possibly a mediastinal mass, keep them upright. You might need to put them on some oxygen, and then you might need to look for your oncologist, radiation oncologist, to be able to see how you can actually reduce the tumor bulk as quickly as possible, and maintaining the safety of the patient. Spinal cord compression, we've also seen that you can have a tumor there, and also spinal cord is also an emergency that is time bound. Within about 24-48 hours of them having paresthesia or pain, if you don't do much, most of the time will end up with paralysis. So this is something you have to be thinking quickly about and deal with it as quickly. And then for the metabolic, we need to talk about tumor lysis, and tumor lysis is what kills most of our patients. Remember, tumor lysis, please put on IV fluids. Start on your fluids. Make sure this patient is passing urine. Even before you give your chemotherapy, please make sure 24-48 hours you're giving aggressive hydration, you started on your allopurinol, and you are actually monitoring the urine output of this patient, so that by the time you start your chemotherapy, then at least those kidneys are well hydrated, and you're monitoring also so that you make sure this patient does not go into renal failure. So I stop there and go now to Hodgkin's lymphoma. And Hodgkin's lymphoma, you remember we said pediatric lymphoma was in two big groups. One was the non-Hodgkin's and then Hodgkin's. So anything that didn't behave as Hodgkin's was actually put under non-Hodgkin's. And Hodgkin's, like just that gentleman seated there, is actually a gentleman. This is one of those diseases that you see patients who come for 1 year. They've been walking around with huge lymph nodes. They've been walking with a mediastinal mass, and they're still, even in your casualty, seated. Yes, they might be a bit breathless, but basically they are not looking that ill. And Hodgkin's actually is the one who described this disease. And basically, for a long time, even oncologists and most specialists didn't really, Hodgkin's has undergone many changes. Sometimes they even called it Hodgkin's disease because people were like, is this really cancer? Because sometimes you see patients who've been 2-3 years having these lymph nodes and looking fairly okay, and they would wonder what it is. But for sure, it is a lymphoma, it's a cancer. And the pathognomonic cell is called the Reed-Sternberg cell, which is a multinucleated giant cell. And that is what you know. And there are two people who described it, that is Sternberg and Dorothy Reed in 1902. And so it was actually called the Reed-Sternberg cell. Now, in 1950s, then they put an association with infection. And this is what we call the Reed-Sternberg cell. If you see this cell, you remember it's giant. It's a giant cell. It almost looks like an owl's eye, owl, or O-W-L, owl's eye, and you can see that. If you see this is a Reed-Sternberg cell, and you see it in a very inflammatory background. So you would see a lot of neutrophils, you would see a lot of lymphocytes, you would see a lot of that in the background. But this is the pathognomonic, and this is one you might only find 2 or 3 Reed-Sternberg cell in one lymph node. So if you did a fine needle aspirate, you could easily miss it. And that's why you really need to get the lymph node biopsy. And there are a few variants that have been described of this Reed-Sternberg cell, and we call them the lacuna or the popcorn cell. And these also are associated with a different type of Hodgkin's lymphoma that also tends to be a bit less aggressive comparing to the classic lymphoma, Hodgkin's lymphoma that we know. Now again, how does this come about? Hodgkin's lymphoma is also one that is associated with a lot of EBV infection, and you can see this germ cell, germinal center cell, B cell. It has a transforming event by the EBV, and then it is transformed. There's loss of apoptosis. There is a lot. This cell tends to produce a lot of cytokines, and that is why you see around the Reed-Sternberg cell, you find a lot of inflammatory response. Now, there are a few histologic subtypes. This is for the classical Hodgkin's lymphoma, which is 95% of what we see. And these are the ones that we commonly know, the nodular sclerosis, and this is what we see a lot in high-income countries. But in our setting, we tend to see a lot of mixed cellularity, and this is the one that tends to be associated most with EBV, and the lymphocyte rich and the lymphocyte depleted are also other forms of Hodgkin's, classical Hodgkin's lymphoma that you might see. Now you remember there's the one we said has like a popcorn cell, a variant of the Reed-Sternberg cell that looks like a popcorn. And this is what we call the new nodular lymphocyte predominant Hodgkin's lymphoma. And this type of Hodgkin's lymphoma is actually so indolent that sometimes it only responds, all you need to do is just to do the surgical excision of the tumor, and you don't need any chemotherapy in some circumstances. But if you see the classical where you see the Reed-Sternberg cell, it most likely will come in these 4 categories. Now, in terms of epidemiology, we tend to see Hodgkin's lymphoma in 2 peaks, and this is where now we find what we have in the adolescent and young adults for us who are in pediatrics, but we also could see it at least in the older generation a little bit more. There is a male predominance in all the 2 peaks. There is a male predominance. How does it present? Painless adenopathy. Most of the time it's usually in the cervical region, but you can have some bit of mediastinal disease. And this adenopathy can also be in the axillary and the inguinal. Now, again, we said Hodgkin's is actually a very systematic disease, tends to be continuous spread, nothing like the Hodgkin's. Hodgkin's is like an unruly adolescent. It's going everywhere. But Hodgkin's is a gentleman and usually tends to have a contiguous spread. So you can see that you have a cervical adenopathy on the left, then you have splenomegaly, and you can see how it basically spreads, and it usually would do that over time. We can have some extranodal sites, for example, the bone, the liver, but rarely in the central nervous system. Tends a lot to be associated with B symptoms, that is the fever of 38 degrees for more than 3 days, weight loss of more than 10% of the body weight over 6 months, and drenching night sweats. And a lot of the time, you can have in 20% of the cases a large tumor burden, and this we characterize it by any lymph node that is more than 10 centimeters or any mediastinal mass that is actually more than 1/3 of the chest diameter. So how do you approach this patient? Again, you do your history and your physical exam. You do your lymph node biopsy, and again, I emphasize on lymph node biopsy and your immunophenotyping. And then you go ahead and do your hemogram just to see where your patient is at. Do your ESR. You'll find your inflammatory markers tend to be elevated, and also they carry a prognostic value. LDH is also usually a marker of cell turnover, is also elevated, and your other chemistries. Now, the CT scans or your images of your chest, abdomen, and pelvis will be able to tell you where else the tumor is at. And in this day, now that we have FDG PET scans, that is also something that you can order for. Again, look at the staging. The staging, again, is very systematic. We use the Ann Arbor staging, and you see for one single lymph node, but in 2 different places. And then if you see in 2 different sites and opposite the diaphragm, and then you have a spread all over or in any of those extra lymphatic tissues, then you know that that is stage 4. So that is something you can easily find in any book. And for us in pediatrics, we've gone on to do something we call risk stratification, and it carries a prognostic value, and you can see if it's stage 1, and A means absence of the B symptoms, and B symptoms, we talked about the fever, the night sweats, and the weight loss. And you can see for intermediate risk what we consider. Anytime you have B, remember you can only be in either intermediate risk or in high risk. And for low risk, it's only 1A and 2A. Anything outside of that is actually put in as intermediate or high risk. And the reason we are stratifying is so that we can be able to treat, and especially for Hodgkin's, because it's one of those diseases that actually is very highly curable. The cure for Hodgkin's now is more than 90% with some very basic chemotherapy, but you also need to be able to determine who do you want to add radiation in addition to the chemotherapy. So again, you notice most of this is actually done by chemotherapy. If there's bulky disease, you combine it with radiation. And usually for advanced disease, we tend to also give 6 to 8 cycles. For low risk disease, you can give between 4 to 6 cycles. These are the prognostic factors. We said the staging, because it always tells you how far is this disease, the bulkiness, and we said if it's mediastinal, more than a third, or any lymph node that is more than 10 centimeters in diameter. B symptoms always tells you there's a lot of inflammation, and remember the inflammatory markers were being produced by the Reed-Sternberg cell, so it tells you about the bulk of the disease. Before, we also used to say the male gender, and elevated ESR again telling you about the inflammation and also the response to treatment after 2 courses of therapy. If you have done 2 courses, you repeat your imaging again. If there has been suboptimal response to that 2 cycles, then this is a patient who most likely will require multimodal and most likely more cycles of therapy. Look at how the response is in terms of treatment, and you can see most of Hodgkin's lymphoma is actually curable, and this is something anyone who fails in treating Hodgkin's lymphoma actually feels very disappointed, because you can't cure them. Now, Hodgkin's is also one that has given us jitters into trying to make sure that we reduce the long-term effects, because you can't cure these patients, but we don't want to cure them and give them other long-term side effects that we can probably not deal with. So a lot of protocols have gone changing. Sometimes some of these things we can't be able to control, some of them we can't, but as much as possible, we try as much as possible to at least retain some fertility. And most of the protocols now are moving away from using some of those alkylating agents that used to cause a lot of infertility. And where possible, even sperm banking is done so that you can have these patients have the option to have children in the future. Secondary malignancy is also something, especially if you've received some types of chemotherapy and also radiation. And remember, this is one where we use a lot of anthracyclines, and so cardiac disease is something that can happen. So I bring this to a close by summarizing and telling you what are the differences between Hodgkin's and non-Hodgkin's disease. And basically what you see, if it's an indolent picture, majority of the time you're thinking about Hodgkin's lymphoma. If we have B cells, we have B symptoms, which is fever, night sweats, and weight loss, this is most likely going to be Hodgkin's lymphoma. If we have an abdominal presentation, majority of the time we are thinking about non-Hodgkin's lymphoma. If we 60% of the time it's usually non-Hodgkin's. Remember, Hodgkin's lymphoma is rarer in children compared to adults. EBB association is with both. The Reed-Sternberg cell is really for Hodgkin's. The starry sky is usually for non-Hodgkin's, specifically Burkitt's lymphoma. Painless cervical adenopathy is more of Hodgkin's, and both of them actually tend to be associated with an immune dysfunction. So I stop there and thank you for your attention. Thank you.
Thank you, Dr. Doreen, for the presentation. That was so informative. As we wait for Dr. Lucy to load, Dr. Kaki. So we'll invite Dr. Kaki to do our presentation next on retinoblastomas. Welcome, Dr. Kaki.
Thank you very much. Actually, we are doing this presentation together with Dr. Jambi, who is a pediatric ophthalmologist and a lecturer in the Department of Ophthalmology. She has a fellowship in retinoblastoma, where she trained in Canada at the Hospital for Sick Kids in Toronto. So she'll do the first part of the presentation to introduce what is retinoblastoma. Then I will talk about the retinoblastoma strategy in Kenya. So Dr. Jambi.
Thank you, Dr. Kimani. I hope you can all see my screen.
I can see.
Oh, yes, we can see your screen.
All right, I'll give you a brief introduction to retinoblastoma, then Dr. Kimani will do the second part. And this is the outline of the presentation. So retinoblastoma is a primitive embryonal tumor from undifferentiated retinal elements, and it is the commonest intraocular malignancy in children, resulting from mutation of the RB1 gene. The common frequency is about 1:15,000 worldwide. And in majority of the time, 40% of the cases are bilateral or germline, and the rest are somatic. And in 90% of the time, it is sporadic, with only 10% being familial. The presentation, it is first diagnosed within the first 3 years of life for majority of the patients. The average age of presentation for the bilateral is 1 year, and for the unilateral is about 2 years, though in Kenya there's a delay up to 35 months. The earliest symptoms, as we can see in the next presentation, slide, the leukocoria is the commonest presentation, what we know as a white reflex, followed by strabismus. And strabismus, it may be with an obvious leukocoria or without. In the late cases, we have orbitocellulitis, swelling and inflammation of the eye. We have blood in the eye, hyphema. We have a pseudohypopion. We have features of high pressure and an enlarged eye, which we call ophthalmos. And in the late stages, you even have proptosis and fungating mass. Here is a child with a white reflex on the left eye, one of our patients. And here we have a child with very late presentation, presenting with proptosis in both eyes. In terms of investigation, we do ocular ultrasound for most of the patients for the diagnosis. And what you look for, especially, is a calcification, which is almost always confirms retinoblastoma, but the accuracy is only up to 87% because some of the cases may not be calcified. And we also use the ultrasound for monitoring the size and the shape of the tumors in conservative management. When we want to monitor the extraocular extension, either prior to surgery or even when you have recurrences, MRI and CT scan are useful. And histology is very, very important because it is vital for the management of the patient, especially for the patients who need enucleation and additional treatment. And when we have spread and metastasis, then CSF cytology, bone marrow aspirate, bone scan, and lymph node biopsy become very, very important. So here we have images. The first one, could get a laser pointer in a second. So here we have the B scan, the ultrasound showing a large intraocular mass. And next to it, we have a smaller intraocular mass, which can be managed conservatively. In this case, the first image, this tumor will need to be enucleated because it is filling the whole eye. But in this case, it is a smaller tumor, which can be treated conservatively. CT scan here is showing calcification and involvement and thickening of the optic nerve. MRI here, the same, showing the enlargement of the nerve, and you can use the same imaging. This patient has a suprasellar mass, in the type that we call trilateral retinoblastoma, where the patient has bilateral involvement of the eye and a pineal gland tumor. In terms of classification, we commonly have the intraocular, international classification of intraocular retinoblastoma. This is what we use in our setup. And this is based on the size of the tumor, the location, and associated seedings of the tumor. So we have group A coming as the small size tumors and at any location in the retina. Group B can be any size, but if it is within 3 millimeters close to the disc or the macula, that moves it to a group B. Group C is a larger tumor but with localized seeds. Group D is a tumor with diffuse seeds, and E is a massive retinoblastoma necessitating enucleation. I'll show you some of the images. So group A, small tumors less than about 3 millimeters in size, but away from the critical structures of the macula and the optic nerve. Then in group B, can be any size, but if it is proximal and very close to the macula of the optic disc, then it becomes a group B. Group C, these are larger tumors, any size, any location, with localized vitreous seeds, as you can see in this patient. So sometimes it can be can look quite big, but as long as the seeds are localized, it still remains a group C. And group D, we have tumors with diffuse and spread vitreous seeds. And group E, as you said, these are tumors filling most of the vitreous cavity with poor visual or no visual potential, necessitating enucleation. Sometimes we have staging. You can use the international staging for retinoblastoma. This one is based on the mode of treatment, where you have stage 0, where the patient is treated conservatively, all the way up to stage 4, where you have metastatic disease. And then we have the AJCC, which we have both clinical and pathological. The same concept. When you have intraretinal disease, it becomes stage 1, and larger tumors becomes, which are localized, become stage 2, larger tumors but spread within the eye, stage 3. Then we have extraocular disease, and metastasis becomes stage 4. And this AJCC has also the hereditary trait stratification, because where we have the unknown, whether there's unknown RB1 mutation, gene mutation, you become HX. Normal alleles is H0, and H1 is when you have the confirmed mutation or a positive family history. Then at the same AJCC, there's a pathological staging, which we highly depend on because it determines the treatment. After enucleation, the same concept. T1 is when you have contained intraocular disease. PT2, you have intraocular tumors but with local invasion. PT3, significant local invasion, but not involving the resection margin. And then CT4, you have extraocular disease with metastases. In terms of management, the principles of management, number 1 is to save life. If you're able to save life, then number 2, you can save the eye. And if you're able to save the eye, number 3, you can save vision. And this is always the strategy, so that you do not compromise life trying to save either the eye or the vision. And the factors to consider, it's the size and the location of the tumor, the visual prognosis, the laterality, whether it is unilateral or bilateral, any threat of metastasis, risk of second cancers, which occurs in those children who have germline mutation, and the systemic status of the child. Treatment modalities that are there: enucleation for group E eyes, for those with no visual potential. We have conservative therapy or eye salvage for eyes that have visual potential, and these are eyes that are from group A to group D. And several options are available, like the laser, cryotherapy, chemotherapy, which can either be given systemically, intravitreal or intra-arterial. There is also the option of brachytherapy, although this one we don't have in the country, and external beam radiation. There is also the treatment for high-risk pathologies based on the pathologic report, and this we use systemic chemotherapy combined with the EBRT. For those who have resection merging of the optic nerve or orbital disease. So let me just go to the next slide. These are examples of patients on conservative therapy, group B to group D. This is a group BI because it is close to the macula and has been treated on laser. And for the children who get focal therapies between group B and group D, we first start by doing chemo reduction with systemic chemotherapy, then we combine with focal therapy. It's only in group A that we go straight and give focal therapy. These are patients with multiple tumors, but here the patient is receiving cryotherapy for a group A tumor that is in the peripheral. So cryotherapy is for tumors that are in the periphery, and the laser is for photocoagulation, is for tumors that are within the posterior pole where you're able to visualize directly. Sometimes when you have persistent vitreous seeding, you give an intravitreal chemotherapy, we inject into the eye, and we have the option of giving intraarterial chemotherapy for tumors that do not respond to systemic treatment. Additional management for the children who receive enucleation, we are concerned about the cosmesis. This is very important, and we usually put orbital implant and give a prosthetic eye. There's also the component of genetic counseling, because if there's family history and all children with bilateral disease, it means that that mutation can be passed on to the next generation or to the siblings in case of family history. So genetic counseling is very important. And follow-up depends on laterality and the staging. So all the children on active globe salvage, that is between group A and D, they are on 3-weekly follow-up, and this many times happens in the theater where we have to give the treatment in theater. And then we have regular examination and anesthesia. For children less than 3 years, it's every 3 months, and 3 to 5 years is every 6 months, and over 5 years, there's annual follow-up for life, especially because of the risk of second cancers. The spread of the disease can be from the eye directly through the sclera into the orbit, that is the local spread, directly to the optic nerve up to the brain, and also through the subarachnoid space into the meninges. We have hematogenous spread commonly to the bone marrow, the bones and the liver, though it's very rare. We have not seen retinoblastoma spread to the lung. And we also have lymphatic spread. So prognosis, early detection is key. We say for retinoblastoma, maybe for other cancers too, time is everything. Because when you have diagnosis, we have good prognosis and life mortality is reduced. Late presentation, we have inadequate treatment and poor prognosis. And the mortality correlates directly with the involvement of the optic nerve, and therefore that is why we advocate in times of enucleation, we get a long optic nerve so that we have a free resection margin, because involvement of the resection margin on pathology is a poor prognostic indicator. And in terms of survival, if the tumor is intraocular, you get up to 95% survival. If you have involvement of the lamina cribrosa or the superficial part of the optic nerve, it goes to 85. Beyond that, then the prognosis is only 55%. And if the resection margin is affected, then survival is only up to 35%. And unfortunately, if there's any metastasis for retinoblastoma, for now, even in the best of centers, there is no survival. And here we have images of some of our success stories. This the first painting or coloring is for one of our patients. We have been following for over 10 years. She still gets multiple recurrences, but she still has good vision. So we have not given up yet. Second baby, unfortunately, this child had bilateral enucleation. So nice that she's looking, she's blind, but she has good cosmetic outcome. And on the right is one of our success boys, both eyes, non-enucleated, treated for bilateral retinoblastoma, but with good vision. Thank you very much.
Thank you for the presentation. Let me invite Dr. Kaaki to present a slide. Welcome, Dr. Kaaki.
Thank you very much, Dr. Jambi, for that, for introducing retinoblastoma. I want to talk about the Kenyan National Retinoblastoma Strategy, because this is one thing that has changed the outlook for children with retinoblastoma in Kenya. So the Kenya National Retinoblastoma Strategy came about when we realized that our children with retinoblastoma, many of them were dying. And in the West, hardly any child dies of retinoblastoma, because retinoblastoma is one of the cancers that is almost 100% curable. When I did my dissertation for my postgraduate in the year 1999, what we found is that there was no logical management plan for children with retinoblastoma. And many of them would die even when they were in a position we could have saved them. So in 2008, we held our first meeting, and we continued having annual meetings until 2015, when our funding dried up. And these meetings were supported by an organization that was known as Daisy's Eye Cancer Fund. This was an organization that was started by parents of a child in UK who survived retinoblastoma, although she had lost both eyes, but they decided they would support other children so that they would also survive. Ministry of Health was also very critical, and also the University of Nairobi, the Department of Ophthalmology, was very supportive. And the participants involved parents, pathologists, pharmacists, oncologists, ophthalmic clinical officers, ophthalmic nurses. We even had a KEPI trainer, the Kenya Expanded Program for Immunization. We had ophthalmologists, and we even had child life specialists. And this was in recognition to the fact that retinoblastoma management is a multidisciplinary, it's a multidisciplinary care, and no one person can manage retinoblastoma alone. We started with a situation analysis on retinoblastoma in Kenya in 2008. And what came out from this analysis, because we had participants from all over Kenya, even as far off as Madera and Moyale. And what came out clearly was that patients were presenting late. There was lack of awareness among the medical workers as well as the general public. In fact, one thing that we came to realize, it is not that parents do not take their babies early to a health facility when they realize something is wrong with the eye, but when they take the baby to a health center or a dispensary, they'll be reassured that nothing is wrong, because the baby looks healthy, they are playing, they are active, they're feeding well, and they're just sent away, only later to present with metastatic disease. There was also a poor referral network and long travel distances for the patient. There was no financial or psychosocial support for patients and affected families, which impacted negatively, especially on follow-up. And there was also no standardized protocol for management of retinoblastoma patients. There was also delay in histopathology report and lack of standardized reporting format. As Dr. Jambi mentioned, histology is the histology report is critical in guiding the ophthalmologist whether the disease has been completely removed at enucleation or there is residue disease necessitating further adjuvant treatment. There was also lack of communication between peripheral centers and referral centers, so that when a child is referred, there would be no feedback for the referring center to know whether the child arrived at the referral center or not. Follow-up of patients was also poor, and chemotherapy drugs were unavailable and expensive. So to look at the facts and figures of retinoblastoma in Kenya, we estimate that we get about 100 new cases of retinoblastoma in Kenya. So it's a rare disease. About 50 new cases are seen at Kenyatta National Hospital per year, and the mean age at diagnosis is 26 months for bilateral disease and 35 months for unilateral disease. If you remember, Dr. Jambi mentioned globally, the figure is 12 months for unilateral, for bilateral disease and 24 months for unilateral disease. And it's not that our patients get their disease later in life, it's just that there is so much delay in presentation that the mean age now becomes higher than what is seen globally. We also found at that point in time that most patients presented late, with 50% having obvious extraocular disease. What this means is that they would come already with the globe proptosed. And the average delay in presentation was about 39 weeks. So from the time the mother notices something is wrong to the time they arrive to a center where they can be treated, that would be 39 weeks. And the 3-year survival was dismal at 26%. And about 28% of patients did not go to a hospital for treatment once referred. So that was the situation in 2008. The objectives of the Kenya National Retinoblastoma Strategy was to improve the 3-year survival to 60% in 5 years through early diagnosis by increasing awareness, standardizing the treatment of retinoblastoma by having best practice guidelines, also family support to ensure compliance, and all this required resource mobilization. So this was the first meeting that we had in 2008. This was at Lukenya Getaway Resort. And that was the opening ceremony, and we had participants from, we had even participants from other places from the world. So we had one of the renowned retinoblastoma specialists known as Professor Brenda Galley from Toronto. And our link with Daisy's Eye Cancer Fund is that lady you see there in dark glasses. She was enucleated as a child, but has survived this far. And we had group discussions to brainstorm on the various aspects. So what are the achievements this far? So one of the things that we have managed to do is that now we have best practice guidelines that have been published by the Ministry of Health, first published in 2014, and we revised them again in 2019. We now have standardized treatment protocols for retinoblastoma. One of the things we did was involve the ocular or the oncology pharmacists, and this helped to improve chemotherapy supply for retinoblastoma. We now also have increased treatment options for globe salvage. When we need to save a globe, we now have more options, including the intravitreal injections that Dr. Jambi talked about, and the highly selective intraarterial chemotherapy. And I must say this was a major achievement because we were the first center in sub-Saharan Africa to offer this kind of treatment, the intraarterial chemotherapy. We also have increased awareness activities, including posters. The maternal child health booklet has something on examination of the eye of a child during immunization. We have also had the opportunity to do radio and TV presentations on retinoblastoma. The other thing that was a game changer was increased National Health Insurance Fund coverage. We we got an organization, Hope for Cancer Kids, that helps parents to enroll for NHIF and actually covers for their first, for a full year and a subscription for NHIF for children diagnosed with retinoblastoma and also other cancers. And we also have a dedicated multidisciplinary team. And because of this, all these activities, we have managed to reduce the delay in presentation by 3 months. That was from about 9 months to about 6.1 months. The age of presentation reduced by 6 months for unilateral disease to about 32.9 months, and by 7.2 months for bilateral cases, from 24.4 months to 17.2 months. Extraocular disease, including on histology, reduced from 37% to 17%. Inconclusive histology report reduced from 13% to 3.2%. And the greatest achievement of all is that our 3-year survival improved from 26.6% to 69% by the year 2020. And successful group salvage improved from 37% in 2006 to 57% in 2020. So this is one of the posters that you might see, especially if you go to health centers and dispensaries. And this is a poster we have tried to spread out throughout the country just to sensitize people about the implications of a white reflex in the eye of a child. This is the maternal child health booklet. And on page 27, it actually explains what the primary healthcare provider who is immunizing the child, they should look out for. They should look out for whether the pupil is black. If it is not black and is white instead, they should refer this child immediately. Also, if they notice that the two eyes are not looking in the same direction and that there is a squint, this is a child to be referred immediately. And then we also have the best practice guidelines that have been published by the Ministry of Health, and these are accessible even on the Ministry of Health website, also in our College of Ophthalmology for East and Central and Southern Africa website. These are also accessible online. We still have challenges, including late presentation. So we still have patients who are coming with a disease that has gone outside the globe. And one of the things we noticed since the what is it called, decentralization of healthcare to county level, for some reason, the number of cases we are seeing with orbital disease are going up. The MCH booklet is also not being utilized well for early diagnosis. There are very few primary healthcare workers using it, and it's just that many of them are not aware of it. In fact, sometimes it's the mother who will ask, you have not looked at the eyes of my child, and in this book it says you should look. So that is still not working too well. There is also failure of some of the ophthalmologists to use these best practice guidelines. We also have the problem of loss to follow-up. We still occasionally lack consumables and chemotherapy drugs, occasional breakdown of equipment. The other big issue we have is that we don't have any dedicated personnel for RB registry, retinoblastoma registry, and so we don't have a database. And you know, evidence, you have to have data for evidence. So every time we need to do a study, we really have to go back to all the files, and which makes it very tedious. And there is also still not very good coordination between the different centers treating retinoblastoma. The lessons learned from this Kenya National Retinoblastoma Strategy, which we believe can be spread even to other childhood cancers, and also we hope that this can be borrowed by other African countries, is that a driver for the strategy is critical for it to succeed. You need 1 or 2 people who will tirelessly be there to make sure that the process is moving. even when people are getting tired. Stakeholders must own the strategy and stay on board. And the stakeholders include even the parents and the survivors of retinoblastoma. And without sustained effort, many gains are lost. And that is the one thing we have seen with the devolution of healthcare. We have lost many gains because now you find that patients are not being referred on time. And ideas must be put into action, and task forces are necessary for this. In fact, like for us now to have a standardized reporting format for pathology, we had a task force for pathology. And so they owned this and designed the standardized reporting format for when we send eyes, enucleated eyes for retinoblastoma. Data is critical for evidence and change, and that is why I'm saying one of the gaps that we have is not having centralized data for retinoblastoma. Partnerships are critical for implementation, and so it's important to maintain any current ones that you have and continuously look for new ones. And it is always important to look ahead and anticipate needs before they arise. For example, the reason why we had to really push and have intraarterial therapy, intraarterial chemotherapy being delivered in Kenyatta National Hospital is because their children, we would be trying to save the only eye. We have done everything, and we would just watch that eye losing vision as time goes. And so we wish that we had actually even anticipated this before we got to the point where we would try to save eyes and would lose them simply because we do not have some of the treatment modalities. I would like to acknowledge all these people who have been critical in bringing together this Kenya National Retinoblastoma Strategy. We had many members, over 60 members from the onset. And also University of Nairobi has been very supportive. Kenyatta National Hospital, a big thank you. And I want to say that right now, Kenyatta National Hospital is the center of excellence for treating retinoblastoma in sub-Saharan Africa. And it is even a better center than you'll find in South Africa. Ministry of Health has also been very supportive. COEXA, this is Eye Cancer Fund, and also Toronto Hospital for Sick Kids. They were very supportive. And especially when we were designing the guidelines, we borrowed a lot from their guidelines. Thank you. So that's the end of my presentation.
Thank you so much. Thank you so much, Dr. Kaaki, for your presentation. We go to the question and answer session, and we are going to start with Dr. Mutua. The first question is, what is fish technology? Hello, Dr. Mutua. Dr. Mutua, can you hear me? Hello, Dr. Mutua. It seems we can't reach out. Dr. Lucy. And she only had one question. And the question was, how does the tumor look like in picture? Is it hyperechoic, hypoechoic, or echoic? Dr. Njambi, I hope
Yes.
you can hear me.
Yes, I can hear you. I'm just if there's any clarification, is that in the ultrasound or how you'd see it in the naked eye? But from
The participant did not.
But from the suggestions, it may sound like it's from the ultrasound B scan where we describe it as hyperechoic because of the way it appears.
Okay, thank you for your answer. And we only had one question for you. We had a few questions for Dr. Kaki. And the first question is, how do you differentiate between retinoblastoma, leukorrhea, and congenital cataracts? Or should we refer congenital cataracts to KNH? Dr. Kaki.
Thank you very much for that question. Let me start by saying that retinoblastoma is one of the cancers that we mainly depend on clinical diagnosis. Actually, most of the investigations we do for retinoblastoma are to rule out metastasis. And when the child is seen by an ophthalmologist, the ophthalmologist will be able to differentiate whether it is a cataract, whether the white reflex is because of a cataract or retinoblastoma. And there are many other things that can cause a white reflex in the eye of a child. But many times when a child is noted to have a white pupil, they should be referred to an ophthalmologist. The ophthalmologist will be able to decide whether this is cataract, whether it is retinoblastoma, or whether this is something else. And and also when it is a cataract, we always advise that B-scan of that eye should be done, because we have seen a few patients where they present with a cataract, but when the cataract is removed, it's only found later that it's actually tumor that was touching the lens and causing the cataract. And once that eye is opened, you change that disease from being an intraocular contained disease to an extraocular disease with very poor prognosis. So any child with a white reflex should be referred to an ophthalmologist, and the ophthalmologist will decide whether this is something they can handle or do they need to refer to a higher center for further management. I hope I have answered the question.
Thank you for the answer. I have a second question for you, and this looks like it's from a parent. It says, hello, I have a 6-year-old with patch on the left eye since birth. The Sabatia Hospital have been doing wait and see approach. It's long since I visited Sabatia. Can I be helped? She turned 6 years old. Any better referral, please? End of the question.
I don't know what they are referring to when they say a patch. I don't know whether it is on the eye or on the eyelid, but whichever the case, Sabatia Eye Hospital is a very good hospital, and they would be able to know whether it's something that requires to be referred further or whether it is something they can manage. So if Sabatia Hospital has not decided to refer, it means that probably it's something they can manage. But the most important thing is that follow-up is very important, and whenever they are given an appointment, they should show up for the appointment and not get tired.
Okay, thank you for that answer. We are waiting for Dr. Kaki to board. Dr. Kaki, can you hear me?
Yes, I can hear you.
Sorry, not Dr. Kaki.
Oh, you mean Doreen?
Dr. Mutua.
Okay.
Yes, Doreen Mutua. As we wait for Doreen Mutua, I would like to make the following information through to the members. It's important to note that September is a Childhood Cancer Awareness Month, and the key message for the drive in this month is that early detection is very important. On MOH Future Academy, there's you can just Google and get there, or you can Google M Saratani on Google Play Store, and IOS. Also important to note is Kenyatta National Hospital have its second annual pediatric oncology workshop next week. That is on 19th and 20th September. The link shall be sent through your email addresses. Therefore, kindly register and plan to attend. Dr. Doreen, are you there?
Yes, I am there, Josephat. My apologies. I had a bit of a technical glitch.
All right,
Yes.
sorry for that, and welcome
Yes.
back.
Okay, thank you.
You have several questions to answer.
Yes, yes.
The first question is, what is fish technology?
All right. So it fish technology is actually look for translocations. So it is called fluorescent in situ hybridization, and it involves, again, cells are taken, they're grown in a culture, then the cells are lysed, they take the DNA material, they have something to amplify it, and then they're able to actually use sort of like if you're looking for a certain translocation, then you use like a bait for it, and then if it is present, it will actually fluoresce, and you're able to see whether that either translocation or mutation is present. So it's a laboratory technique, possibly done in more of molecular labs, to be able to look for certain mutations within the DNA. Yeah, thank you.
Okay, thank you for that answer. Your second question is, how can a misdiagnosis be avoided?
Okay. Misdiagnosis of lymphoma and especially TB in our setting, and the reason
An
why.
example of the baby was being treated.
Or for tuberculosis. All right. So that's a very good question, because we get a lot. Tuberculosis is quite common, and one of the things, for example, if you're in a setting where the typical history, you have this child who comes in with cough and weight loss and night sweats and all that, and maybe there's a positive or no positive history of contact with tuberculosis. Sometimes you have had patients put in on treatment for tuberculosis, but one of the things I always say is, once you start your tuberculosis, within 2 weeks, you will actually see a remarkable improvement. If you review this patient and in 2 weeks, you actually find that the lymph nodes are even getting bigger, the lymph nodes have not changed in size, then chances are this is a time to actually go back and ask yourself, what could we be missing? Sometimes lymphomas in our settings, we have had patients who actually have both. They actually have lymphoma and also have co-infection with tuberculosis because of the lowered immunity. So having a high index of tuberculosis is very good, but also knowing as a frontline health worker that if tuberculosis treatment is suspected or investigated and you are now on the right treatment and it doesn't improve, please don't put lymphoma very far from you. And this is something you probably should really send, either refer or investigate in your setting. Yeah, thank you. Okay, and I think I saw a question again in terms of when to do, why insist on a lymph node biopsy? What if in my own area, the only thing I have is an FNA? And again, because I know we practice in different parts of this country and we have different limitations in resources, again, I say, if you do an FNA, you might catch the disease. You probably also are very likely that you might miss the diagnosis. The reason is I'm right now in Gertrude's Children's Hospital, and I keep looking at an FNA. Like, for example, if you come and look for Dr. Karemi in Gertrude's Children's Hospital, I'm seated right in the doctor's room. If you go to casualty, you'll be told I'm not in the hospital. If you go to the HR, you'll be told I'm not in the hospital. If you go to the cafeteria, I'm not in the hospital. And that is exactly what happens with an FNA. You're only looking at a single area. But I am right in Gertrude's, and I'm right seated in the the doctor's room. So the benefit of having a lymph node biopsy is you can be able to scan all through Gertrude's Children's Hospital and be able to zoom around and be able to actually see, is Dr. Karemi really seated in this hospital? Is she there? And the chances you'll be able to catch that tumor will be much, much higher. So if you have an FNA, then go for it. Use that, use what you have. But remember, there are very high chances you might not get a conclusive a conclusive answer. And a lot of the time I see people looking for me and saying, I did an FNA of the lymph node and it actually said a reactive picture. But when you look 3 or 4 months down the line, you are confirmed a diagnosis of lymphoma. So that is again time wasted, resources wasted. So I always urge, why don't you just go for the definitive? Look for a surgeon. It might be difficult. If you can't get a surgeon, refer to a center with a surgeon. A lymph node biopsy is done and proper diagnosis is done, and we save the patient time and money, and we get the right diagnosis and start treatment early. So thank you very much for that question.
Okay, your last question was, I think it was a request. This is not a question. Can you share a soft copy of the presentation? And I think that will be addressed by the research team.
Okay, that's wonderful.
Okay. Dr. Kaki, are you on? We have a few questions for you. Actually, two.
Yes, I'm on.
Okay. The first question is, we have few ophthalmic experts in the country. Is there a strategy by the Ministry of Health to reach to rural communities who might miss early diagnosis, leading to poor prognosis?
That's a very good question, and it is true that we do not have many ophthalmologists. But if every primary healthcare worker was to utilize the MCH guidelines the way they are meant to be utilized, they would be able to refer a child to the nearest ophthalmologist, and such a child would be assisted early before the disease spreads. So the strategy by the Ministry of Health is having the MCH booklet with enough information on what somebody should do when they notice there is a white reflex or there is a squint in the eye.
Okay. Thank you for that answer. The other question is, what pattern of retinoblastoma is more prevalent locally? Is it hereditary or sporadic?
So as Dr. Jambis said, 90% of new cases of retinoblastoma are sporadic. There will be no other child or family member who will ever have had retinoblastoma. It's only 6 to 10% who will have a positive family history. But you remember she also mentioned that especially for those children with bilateral retinoblastoma, those are children who, if they survive to adulthood, their children have risk of having retinoblastoma. And not just the ones with bilateral disease. About 15% of those with unilateral disease also have that germline mutation that can be passed on to the offspring. And unless one is able to do genetic testing, it is not possible to tell which child, especially the ones with the unilateral retinoblastoma, has the risk of passing on the disease to their offspring and which one doesn't. So like in Kenya, we currently don't have the facility for genetic testing. We are working on it and we hope it will be available soon. So currently we treat every child as if they will pass on the mutation to the offspring. I hope that has answered the question clearly.
Sure, thank you. Another question for you. Can NI neighbors be cancerous?
A nevus is very, very rare for it to undergo malignant transformation. But we always advise when there is a nevus, there should be regular monitoring. But it is very, very rare that it would ever change to become malignant. So by and large, most nevus are harmless. It's only that they don't look nice on the eye, but they're harmless.
Okay, thank you for that answer. Probably the last question. There are some times you find some kids have bluish and yellowish eyes and a presentation of watery discharge. Is this a sign of retinoblastoma?
No, many of those children who have discoloration of the surface of the eye, that would be because of allergy, and watering and discharge, that would be because of allergy. The color that we are talking about is the pupil, the center inside the eye, that will look white instead of black. But the surface of the eye usually will not, the color will not change, unless now when they have very high pressures, in which case the eye will become big and appear bluish. But when it's on the surface and watery, then most likely it is allergy. But we always advise, if a child is noted to have any eye problem, it is always good to take them early enough to the eye clinic so that they can be assisted and the problem addressed. Thank you.
Thank you for that answer. As we conclude our presentation today, our webinar today, I would like to remind you that September is a Childhood Cancer Awareness Month, and early detection is important. More courses can be found on MOH Future of Virtual Academy or M Saratani on Google. And of importance is Kenyatta National Hospital have its second annual pediatric oncology workshop next week on 19th and 20th. Kindly, you register through our link that will be shared through your emails. I would not wind up without thanking all the participants and our presenters, Dr. Mutua, Dr. Nchambi, and Dr. Kaaki. Thank you very much for participating. Goodbye.
Thank you.
Thank you.
Thank you.